So good morning, everybody, or good afternoon, or good evening, depending from where you are joining us. Tonight, the IVPN NeuroPsychiatry, supported by Novartis, is organizing the sixth and last neurology virtual clinic, our one-of-a-kind learning experience. During this educational activity, our top-notch multiple sclerosis experts will share with you real-world clinical cases. Therefore, I would like to invite you to interactively participate by analyzing the cases shared and by voting to the poll, as your participation will definitely make it a fruitful meeting. Motor and sensory deficits are among the most common symptoms of the disease. However, multiple sclerosis disease. However, cognitive impairment are also frequent in MS, since they are experienced in about half of the patients and are sometimes observed after the first demyelinating episode and even in the early phases of relapsing remitting multiple sclerosis. And depressive symptoms and anxiety also influence cognition in MS and are frequently seen in those patients. For instance, patients with anxiodepressive symptoms are 4 times more likely to show cognitive deficit. Finally, fatigue is also a major symptom of multiple sclerosis and also might have an impact on cognition. In fact, 75 to 86% of our MS patients experience debilitating fatigue that interfere with their daily life activity and affect their quality of life. And while the severity of cognitive impairment is not linked to disease duration, it is determined by the course of the disease. So patients with progressive multiple sclerosis, mainly patients with secondary progressive MS, often have cognitive impairment in addition to physical impairment and mental health problems. And the burden of this cognitive, mental, and physical impairment progresses over time and be major determinants of quality of life. Therefore, it's very important to prevent progression and, if not, treat SPMS as early as possible. This is the subject of our virtual clinic tonight. And in our first session, Dr. Suzanne Nouri will discuss secondary progressive MS, focusing on the effect of SPMS new therapies on cognitive impairment, fatigue, and depression. Dr. Suzanne Nouri is the owner and director of Dr. Suzanne Nouri Medical Center in Dubai. She is a senior consultant in neurology at University Hospital Sharjah and associate professor in the Medical College of University of Sharjah. She has obtained her MBBS degree from the University of Khartoum, her clinical MD in medicine from the University also of Khartoum, and she's a fellow of the Royal College of Physicians of Edinburgh and a fellow of the Royal College of Division of Glasgow and a member of the American Academy of Neurology. Dr. Nouri holds a co-joint academic responsibility in the Medical College in the University of Sharjah and an active member in the research group at the university. She also has obtained postgraduate degree in the management of multiple sclerosis from Leeds Metropolitan University. She's a member of many professional bodies locally, regionally, and internationally, as well as a member of many quality committee and task forces. She is one of the main founders and currently the head of the scientific committee of UAE MS support group. She has been actively involved in different meetings and forums as well as in the media and had coordinated regular campaigns for raising awareness for multiple sclerosis in her community. Dr. Suzanne, it is a great pleasure to have you with us tonight as a speaker. Welcome, and the floor is yours.
Thank you very much, Dr. Maya, for this kind introduction. And I'll just stop your screen to show mine. A second, please. It's my great pleasure to be here this evening to share with you my thoughts on the cognitive impairment in patients with secondary progressive multiple sclerosis, because this topic needs to be elaborated more about, because it's a hidden symptoms usually nobody talks about. So this is my disclosure. And my outline talks of tonight, I will be discussing the prevalence and the profile of cognitive impairment in patients with multiple sclerosis, the population at large. And then I'll talk about the burden of cognitive impairment in MS, what are the affected domains, how to measure cognitive impairment in patients with multiple sclerosis, and then to emphasize on the importance of early diagnosis, recognition of comorbidities like depression and fatigue, as we just mentioned, and also monitoring the impairment of cognition. Then we will discuss the rationale of treating cognitive impairment in MS and how to improve or to treat this cognitive impairment. And we will touch on the therapeutic approaches, since we have some medications that can act on this. So from a historical aspect, cognitive dysfunction in multiple sclerosis patients can be tracked back to Charcot in 1800s, when he described the memory and emotional changes in patients with multiple sclerosis. However, this wisdom was historically unappreciated until 100 years later, when researchers began to scientifically investigate and understand the issue of cognitive impairment in people with multiple sclerosis, and that was only started in 1980s. Cognitive impairment is a term that is usually used very loosely by people. So when we say that a person complains of brain fog or challenges with concentration and attention, then the conclusion will be, oh, they have cognitive impairment. But in fact, cognitive impairment specifically refers to deviation from normal performance on neuropsychological tests, and is typically a deviation from the normal functioning in more than one domain. So cognitive impairment affects a large proportion of patients with multiple sclerosis, and the prevalence ranges anything between 40% to 70%, which is making mental health an issue, and as well as the diagnostic and quality of life an issue for this type of patients. And this also affects their relationship, their occupational and vocational status, and they also affect the long-term health outcomes. Classically, multiple sclerosis associated cognitive impairment has been labeled as cortical MS or cerebral MS, and sometimes we call it, or they call it, subcortical dementia. And this is a differentiation from Alzheimer's disease, which we call like cortical dementia. And it's often present as profound slowing of cognition, and that's also referred to as bradiphrenia, which is a medical term for the slowing of thinking and slowing of the process of information. Additionally, they can manifest as psychiatric symptoms, personality changes, mood disorders such as depression, anxiety, apathy, irritability, and in MS, cognitive dysfunction or cognitive deficits occur independently of their physical disability. And it is quite important to recognize, because it can occur as early in the course of the disease. And actually, cognitive dysfunction in patients with multiple sclerosis can occur with any type of multiple sclerosis. It's quite common. So it can occur in all types of multiple sclerosis, in radiological isolated syndrome, in clinical isolated syndromes, and even in pediatrics multiple sclerosis. However, it affects more people with secondary progressive multiple sclerosis. As you can see that the incidence here almost double that the incidence or the prevalence occurs in patients with relapsing remitting multiple sclerosis, 40% versus 87%. Cognitive impairment can appear early in the disease, as we mentioned, and the prevalence tends to increase over time. So as the disease progresses, the cognitive impairment appears clearer and clearer. And here we can see that within 5 years of disease onset, approximately 50% of patients started to show mild to moderate cognitive impairment. And how do these patients present? Patients usually report becoming easily distracted, having difficulty in learning and remembering information, having difficulty in doing more than one task at the same time, forgetting names, forgetting appointments. And if we screen these patients at this stage, we may find decreased information processing speed, which is usually the most affected domain. And it's the red flag, which indicates that we should investigate these patients further. Maybe we need to reevaluate, and if it is still abnormal, then we need to refer for more neuropsychological testing. They can have also attention problems, sustained attention issues. They can have decreased short-term memory. They can have learning problems, and they have decreased ability, of course, in doing multitasks. And all these signs corresponds with the symptoms that they usually present with. Although almost any pattern of cognitive defects can occur in these patients, the typical profile of impairment of information processing speed memory. And here is the community-based study comparing 100 of multiple sclerosis patients with 100 healthy controls, tested on extensive neuropsychiatric battery, and it's showing prevalence of impairment by the cognitive domains and the pattern of the domains affected. So we can see here the information processing speed and episodic memory are the predominantly affected domains in these patients. And less frequently, we have the executive functions affected, including verbal fluency and word generation. If you can see also that the language and the simple attention is less frequently affected in this group of patients. And this was more pronounced in secondary progressive MS patients when compared to RRMS relapsing-remitting patients. And you can see in this one, there's a huge decrement of the information processing speed and the working memory in patients with secondary progressive multiple sclerosis. How do cognitive problems affect the lives of people with MS? Considering the fact that the majority of MS patients are young or middle-aged population, the effects of the dysfunction in this population usually can be very dramatic, and they can have devastating effects that affect their professional life, social life, family lives, and overall, they will end up having a poor quality of life. According to the extent of cognition affection, the researchers or scientists have categorized MS patients into 5 phenotypes. We have the preserved cognition, and this usually characterized by preserved functioning in all cognitive tests. And that was characteristics of patients at the early stages of their disease. And the only imaging features noted in this group was there is a slightly lower volume of the thalamus compared to the healthy control when they did the MR for these patients. This is group 1. In the second group, we call it mild reduction in verbal memory and semantic fluency. This is associated with hippocampal atrophy when we did MRI. And then we have the group who have mild multi-domain. And this is characterized by mild decreased cognitive performance on several tests when it was the neuropsychological tools were used, and it was associated with cortical atrophy. Then we have a group of severe executive attention deficits, and this characterized by decreased performance on all the tests, particularly assessing attention and executive function. And this phenotype was characterized by higher fatigue, and they scored also high on the MRI in terms of the lesion load. Then we have the last group, which is a severe multi-domain, which is characterized by severely decreased performances in all the tests, all the domains of the cognition, and the patients have severe generalized brain atrophy, and this type of patients associated with severe depression. So what is the pathology of the cognition in patients in general? So this is very complex. I will try to simplify it, and it's actually beyond the scope of this talk. The knowledge of the correlation between the lesion location, brain network, and the relation to objective cognitive function among persons with multiple sclerosis is still growing. So we do not have a strong evidence of what is happening in the brain. Cognitive function relies on complex interconnections between the cortical, which is cerebral cortex, and hippocampus, and the deep gray matter structures like the thalamus and the basal ganglia, with adjoining white matter tracts being an important conduits. So in the cortex, we have the pyramidal neurons, which connect the cortical structures together. So we have the cortical connections, or we have the projection to the subcortical areas to form functionally distinct and temporary coordinated networks. And this you can see in the purple lines as illustrated in this figure. So what's the underlying pathology? Why do these patients develop cognitive dysfunction? Not very well understood, but however, it's different mechanisms have been proposed to get involved, including chronic inflammation, disruptions of the neuronal axonal compartments, oxidative stress, and also alteration in the cerebral metabolism or the blood-brain barrier, all lead to changes in the cortical and cortico-subcortical connectivity. And as I said, this is very, very complex thing. And this is just a simplification of what I could explain it. Back to clinical, researchers have evidence to suggest that cognitive impairment is a very good predictor of physical disability progression in patients with multiple sclerosis. And that's why it's quite important to assess our patients on a cognitive level so that we can have a clue for the progression of their disease. Here we have a retrospective 8-year longitudinal study involved 78 relapse-remitting multiple sclerosis patients assessed by the neuropsychological examinations and structural MRI at time of the diagnosis, 6 monthly afterwards, and at the last follow-up. And the reports of this was the cognitive impairment at the time of diagnosis was found to be a predictor of conversion to definitive multiple sclerosis, disability progression, as well as transition to secondary progressive phase. So it's a very good predictor if correctly identified. Other factors that worsen the cognition in MS patients is the sleep disturbance, and this is considered like a confounder factor, so that we have also to dig and look for that. Very commonly seen in patients with multiple sclerosis, and the prevalence almost exceeds 50%. And the sleep disturbance contribute again to the chronic symptoms like the fatigue, which is again a confounding factor to cognitive impairment, and all this can affect the psychological well-being of the patients, their physical activities, and their social and professional capabilities as well. Fatigue and depression frequently coexist. So most of these patients, they have both symptoms together coexisting with the complaints of cognitive impairment, and this might be quite hard to differentiate between whether it is a fatigue that they suffer or it's a depression that have the problem. Fatigue, as I said, present in almost 97% of patients with multiple sclerosis, and the depression at least in half of these patients, and both have pathological basis and associated with increased certain inflammatory markers in the CSF, but I'm not going to discuss it because we do not have enough time for that. So how do we do cognitive assessment in clinical practice, let's say? So the objective assessment of clinical impairment or clinical deficiency is very critical, as mentioned. Even before the patients had symptoms, we have to look for this impairment of cognition. On the basis of the results, the neurologist should consider testing cognitive processing speed to identify those patients who are at high risk of disease progression. Clinical interview and the clinical neuroexamination are not sensitive to detect cognitive impairment for patients with multiple sclerosis. So our normal visits, normal examination is not sensitive, and actually our accuracy at identifying cognitive impairment is no better than just a chance. So cognitive impairment is more subtle in patients with MS than in other neurodegenerative diseases as compared to dementia. So that's why it can be easily missed if we do not look for it specifically. So, and we cannot rely on patients reporting or self-reporting, because simply what we know that patients with multiple sclerosis, especially with progressive MS, they have diminished insight, and the cognitive impairment by itself It impairs their self-awareness, as well as the mood disturbance and fatigue affect their perception of cognitive disturbance. So you cannot count on patients reporting on their cognitive impairment. And neither EDSS that we usually use to assess the physical impairment of the patients is sufficient to capture cognitive impairment, and patient can suffer profound cognitive impairment while the EDSS still remain on the zeros and ones. MRI and functional MRI may be used as biomarkers for cognition and just looking for the features of brain atrophy on a specific thalamus or hippocampal area or generalized brain atrophy. Or sometimes we also need to look for the cortical thinning because this is the best biomarker that we have so far to assess cognition. Neurofilament in the serum not convincingly relate to the cognitive performance, so it's not a good biomarker. How do we screen for cognition in the clinic? We have to use certain tools for assessment. And the tool that we should use should be appropriate, should be brief, should be reliable, valid, and cost-effective, of course, and should not be used within 1 month after the relapse, because definitely there will be some compounding effect, whether of steroids used or medication used or whatever condition the patient suffers from. And the goal of the neuropsychological evaluation is to characterize the pattern and the severity of the cognitive dysfunction and determine whether this is a real symptom of MS cognition deficit or it can be explained by any other comorbid diagnosis. So the tools that we use, we have the PASAT, that is a Pace Auditory Serial Attention Test, and we have SDMT, the Simple Digit Modality Test. We also have the Brief Repeatable Battery or Neuropsychological BRBN, and we have the Brief International Cognitive Assessment for Multiple Sclerosis or BICAM, and this is the best as most of the scientists evaluated. So the PASAT, it is a measure of information processing speed and calculation ability. It uses single digits presented every 3 seconds, what we call it PASAT 3, or every 2 seconds in PASAT 2. And what is required from the patient that they should add each new digit to the one immediately prior to this. So we have the 5, we have the 1, then we have the 5 that is 6, 6 to the 5 that is 11, so on and so forth. It takes some time actually for to be completed. Then we have the Simple Digit Modality Test, SDMT. This is a much easier one. It doesn't take time, 2 to 5 minutes to complete. It assesses processing speed, and it has proven to be the most reliable and valid psychometric measure for the neuropsychological status of the patients. Sensitivity is high, 82%, and specificity around 60%. The other test, the BRB, this is, includes several sensitive tools to measure cognitive dysfunction associated with multiple sclerosis. However, it requires a long time, around 40 to 45 minutes to complete, which makes it not practical to be used in the clinic settings. In addition, it neglects domain of higher executive function and spatial processing, which makes its reliability very questionable. Then the last tool that we'll talk about is the Brief International Assessment of Cognition of Multiple Sclerosis, or BICAMS, and this includes a set of measures, and the 3 cognitive tests that it involves are the verbal memory, the visual memory, and the cognitive processing speed. So it covers most of the domain affected in multiple sclerosis. It takes good 15 to 20 minutes to complete, and actually most people, they do not have the time to do it, and also, or they do not have staff to do it. So this is just to remind that I know that everybody knows this test, the clock drumming test and the MOCA test. These are the tests that we use usually to detect patients with mild cognitive impairment or Alzheimer's dementia. So these are not effective at all in patients with cognitive impairment in multiple sclerosis. What we need to use, actually, we can use, this is what's recommended cognitive impairment in MS. You can use the SDMT alone as in a brief good screening test, or you can use it in combination with the rest of these tests. So this is just to remind you that after the initial assessment, we have to do the re-evaluation if required, and we need to exclude also the confounders. and the patient can be referred for more extensive neuropsychological testing if required. So at the time of cognitive assessment, as I mentioned, it's very critical to assess for confounders like fatigue, recent relapses, because all can affect the result. We look for depression, concomitant medications, sleep problems, because all of these will change the results of the tools. How can we treat? Okay, so the best treatment is prevention. Okay, by targeting the disease early and more effectively, especially now we have disease modifying therapy that can delay disease progression and can reduce the risk of cognitive decline. So prevention is better than cure always. So of course, historically that no treatment was approved for cognition or showed that it reduced the cognition in multiple sclerosis. We have so many diseases, disease-modifying therapies that have been approved for multiple sclerosis, but none has shown effect on cognition. And most of the trials have not been powered or planned to demonstrate positive effects on cognition. We have now, we can just talk about this one. Just give me a second. Yeah, this again showed that from the clinical trial data comparing different DMTs, including mitoxantrone and cladribine, no DMT has shown slowing of disability progression, nor slowing of cognitive impairment in patients with secondary progressive multiple sclerosis. Only siponimod in EXPAND study, which is a phase 3 study of siponimod versus placebo, where the results showed that siponimod specifically and significantly reduced the risk of disability progression in patients with secondary progressive multiple sclerosis, and siponimod significantly also reduced gadolinium enhancing T1 lesion in patients with secondary progressive multiple sclerosis, as well as it reduces the new or enlarging T2 lesions compared with placebo up to 19% in the treatment group. And the siponimod also reduced MRI brain activities and has been shown to preserve brain volume over 2 years as compared to placebo. The SDMT was assessed as an exploratory endpoint of the EXPAND study, and which assessed cognitive processing speed in multiple sclerosis, as we mentioned earlier. Siponimod was associated with significant benefits over placebo in cognitive processing speed, as measured on the SDMT. And specifically, it measures what we call the 3 points and the 4-point change in SDMT, because we know that patients who perform very poorly on SDMT are more likely to lose their jobs because of the impaired cognition. So this considered like the SDMT 3 and 4 points are as meaningful points in terms of employment status. Here, siponimod reduced this risk of clinically meaningful cognitive worsening, again, as compared to placebo in the EXPAND study. So before I conclude, here are some practical tips. We need to assess cognition on annual basis. We need to assess on the baseline as well as on annual basis, or more frequently if required. We need to use simple screening tests. And if there is any concerns, we can refer for more comprehensive neuropsychological assessment. And we should always look for, identify if for the presence of any confounder. So my take-home message is cognitive impairment is highly prevalent in patients with multiple sclerosis and has a strong impact on quality of life and employment. And until now, there is no reliable biomarkers for cognitive impairment, if any other than the cortical pathology, MRI brain. And the processing speed, working memory are the two main domains affected in most of these patients, especially in secondary progressive MS. Cognitive impairment is a very good predictor of physical disability and progression in patients with multiple sclerosis. So we have to keep an eye on this so that we can predict the patients and then we can interfere at appropriate time. Therefore, early detection of cognition and impairment and psychiatric distress in this population is critical to allow for early treatment intervention. And with that, I would like to thank you for your attention.
Thank you, Dr. Suzanne, for an excellent presentation and overview about all these symptoms that severely affect the quality of life of our MS patients. And please allow me to take some questions.
Sure.
So the first question, brain atrophy could give or could be or give an overview about cognitive impairment or could predict cognitive impairment in MS patient. So do we measure brain atrophy routinely in clinical practice, or is it only up till now reserved for research and clinical trial?
Very good question. Actually, brain atrophy is not measured in routine clinical practice. And as you mentioned correctly, it is still a research tool, but we do not have any clinical meaning to measure the brain atrophy in our practice. But it's quite important to have a look at this.
Another question, how do we optimize depression treatment in MS patients? So do we use antidepressant? Do we recommend frequent visit to psychotherapists? So how to optimize depression treatment in MS patients?
Right, okay, so depression in multiple sclerosis occurs as a primary depression or a secondary depression. So we have to differentiate whether it's a primary or a secondary depression. Primary depression is quite common in multiple sclerosis, as well as the secondary as the result of many other factors, as we said, that the confounder factors as well. So for treatment of depression and multiple sclerosis in general, the treatment usually should be a multidisciplinary approach for these patients. So they will need assessment by psychologists, and if needed, of course, they will be on some medications. But if it is a secondary type of depression, of course, we have to find out the underlying cause.
So siponimod is approved for the treatment of secondary progressive MS. So in the phase 3 clinical trial, does it show a decrease in brain atrophy or in brain volume loss compared to placebo?
Yes, there is a 2-year follow-up for patients for the study. So it shows that there is a decrease, and I showed that in one of the slides. It will reduce the brain atrophy in the patients, or actually the volume, will say the brain volume loss in patients with multiple sclerosis, quite well reduced in MS patients who used the siponimod as compared to placebo. And actually, as I said, the secondary endpoint, the exploratory endpoint for the DMT, where they checked for the cognition, which correlate with the brain atrophy. Also, siponimod group showed better results as compared to placebo group.
How do we measure fatigue in MS patients?
There are certain tools for measuring fatigue. So we have forms, we have like questionnaire for measuring the fatigue, different types of questionnaires. So this can give a clue for fatigue in these patients. Again, fatigue can be primary fatigue or can be a secondary fatigue. So also we have to look for the cause for it.
Yeah, sure. Those were the questions. Thank you, Dr. Suzanne, for your presentation and for joining us tonight.
Thank you very much.
Thank you. And with no further delay, we will be moving to our second multiple sclerosis expert, Professor Gavin Giovannoni, joining us from the UK. So Professor Giovannoni is the Professor of Neurology at the Bilzar Institute, Barts, and the London School of Medicine and Dentistry at Queen Mary University of London, and the Department of Neurology at Barts Health NHS Trust. His clinical interests are multiple sclerosis and other inflammatory disorders of the central nervous system. He's particularly interested in clinical issues related to optimizing MS disease-modifying therapies. His current research is focused on Epstein-Barr virus as a possible cause of a multiple sclerosis, defining the multiple sclerosis endophenotype, MS-related neurodegeneration, biomarker discovery and validation, and multiple sclerosis clinical outcome. His team focus on translational research and therefore have an active clinical trial program. Professor Gavin will discuss SPMS in a case-based format. Thus, I would like to remind you and encourage you to actively participate by voting to the poll during the clinical cases discussion. Professor Giovannoni, we are honored to have you with us tonight. Please start your presentation. You are muted, doctor. You are still muted. It shows that you are muted.
Okay.
Yes. Okay, we can see your slide. But you are again muted.
Can you hear me now? Is that better?
Yes, now. Yeah,
Okay.
Now it's perfect.
Okay, so look, I want this to be interactive. So we're going to have a few little questions and ask, put the questions into the discussion box, and we will stop and discuss things as we go along. So this is about looking beyond the surface of secondary progressive multiple sclerosis. So the case is something that you may see in your clinic every day of the week. It's a 38-year-old woman with secondary progressive multiple sclerosis. So she was diagnosed 14 years ago at the age of 24 after she presented with optic neuritis and had a prior history of vertigo and unsteadiness of gait that was actually mislabeled as labyrinthitis. So MRI showed dissemination in time and space, and she was diagnosed and put on interferon. And she was on it for 8 years, and then she switched to fingolimod because of a relapse. And she's been on fingolimod now for 6 years, and she's been free of relapses, and her MRI scans have been stable, no new lesions. She has moderate neurological impairment. Her EDSS is 4.5, so she's in that zone where she's getting worse from a walking perspective. And she's noticed worsening weakness in her lower limbs, okay, over the last 2 years. She suffers from severe fatigue, which is worse during menstruation. She has bladder problems, for which she's on oxybutynin 5 milligrams twice daily. And she's also on baclofen 10 milligrams 3 times a day for some mild spasticity and limb jerks at night. And she's recently split up with her long-term partner and had to stop work as a bank clerk because of the fatigue. So you identify this patient, okay? So the question I want to ask you now is, does she have secondary progressive multiple sclerosis? So could we have a little survey up there? Is that possible?
Yes, of
I
course.
think there's going to be a,
So
yeah, there we go.
They can vote. So Professor Gavin is asking you, does she have secondary progressive MS? Yes, maybe, or no? So we'll allow 30 seconds for voting, then we'll show the results on the screen.
People are voting.
Yes.
So you got to think about your definition. So there are different definitions of secondary progressive multiple sclerosis, but the one most of us use is the George Ebers one, where you see somebody who's got a history of worsening, and you document in the notes this person is worsening, and it's independent of relapse activity. Okay, and then what happens is you see them in 6 or 12 months' time, and they're still getting worse, provided they've got clinical signs. Then you will label them retrospectively as having secondary progressive MS. So based on that definition, let's see what you say.
I'm ending the poll now.
Okay. So most people, only 6% said no, most people said yes. So the point I was trying to make is it depends on your definition. Now, if you are working at MS Base in Australia, they would use a metric-driven system, and their definition is when you reach EDSS 4 and it's confirmed at 3 or 6 months, provided you've got pyramidal weakness in the so-called EDSS functional system of 3 or more, then you've got secondary progressive MS. So I personally believe that she does have secondary progressive disease, but you'd have to have documented this worsening over a 6 or 12 months. So based on this scenario, you can't tick the box for a definition, but clearly this woman has got secondary progressive disease. So the next thing, so her main problem is fatigue. How are you going to manage it? So now the problem about MS fatigue is a dumping ground. Okay, so I'm going to go through some of the issues around MS fatigue. She's just lost her partner. She's just lost her job. So one of the things that you've got to always ask the question, is the fatigue part of a mood disorder? So the question is she depressed or anxious? Maybe you want to give it a guess. Do you think she's got depression? Yes or no? As you know, anybody with mental health issues, be it depression, anxiety, or an overlap depression, anxiety, part of that symptom complex is fatigue. So they all fit together. Fatigue, depression, and anxiety, they fit together. And so I haven't told you about her mood. I know this patient very well, and I want to ask you the question, do you think she's depressed?
I'm ending the poll now.
Okay, open the poll. What do you think, Suzanne? Do you think she's depressed? Yep, so there again, it's almost 100% of people, just a few said no. Obviously, you've got to take a history, but this particular patient was significantly depressed, all right? And another thing I haven't pointed out is she's become socially isolated because she's broken up with her partner, and she's living alone. Actually, she doesn't have children, okay, and she's not going to work. She's also become socially isolated, which is another issue that you need to be aware of, okay? And so you have to take a depression and a mental health history, and you're going to have to get her depression sorted out. And you heard by Suzanne's talk what we do for depression in multiple sclerosis, okay? I personally manage it in multiple ways. We would get her general practitioner to send her for social prescribing. In other words, get her to join art groups, gardening groups, so she increases her social capital. She'd have to go off to a therapist for CBT and mindfulness, and almost certainly she may need an antidepressant. And the antidepressant you use depends on other factors, okay, which one you use in this individual. The other question is, does she have a sleep disorder? Yes or no? I didn't give you the history. I'm using this as a prompt to make you think about how you approach a person with secondary progressive disease in clinical practice who has this kind of history.
So, Professor Gavin, do people with MS in general, is it common to have sleep disorders among people with MS?
We will see what people guess here.
I'm ending the poll now.
Okay. Okay, so there, I mean, this again, it's almost 100%. So we are actually, I'm actually priming you. So when you take a history of this individual, okay, she does have a sleep problem. She's got nocturia, so she gets up several times at night to pass urine. She's got leg spasms, which her baclofen is partly controlling, and she wakes up frequently at night, and she never wakes up in the morning feeling like she's had a good night's sleep. And so the question you got to ask is, well, is her fatigue due to her having a sleep disorder? And I think it's important to realize that most people with multiple sclerosis, when you take a sleep history, will tell you that they have a sleep disorder or a sleep problem. And so you have to take a really good sleep history. So what you need to ask her is, what's her sleep hygiene like? Is she sleeping during the day? Is she using too many stimulants in the day and they're not wearing off? And this often happens with some of my patients. They take their caffeine or they take their modafinil too late in the day. Some people are self-medicating with too much alcohol. Some people have pain, etc. So you've got to take a really good sleep history to try and improve sleep hygiene. Another problem is when people have mental health problems. As you know, with depression, one of the vegetative features of depression is sleep disorder. They don't get off to sleep or they don't stay asleep. So unless you manage her depression, the sleep's not going to sort out. And the other thing that I must point out is that when you put people with multiple sclerosis into a sleep laboratory, okay, about half of them, just like slightly less, it's about 45%, will have obstructive sleep apnea, which is about 3 times higher than you get in the general population. In the general population, that figures around about 12 to 15%. That's quite frightening, isn't it? That of adults put into a sleep lab, about 12 to 15% will have obstructive sleep apnea. In multiple sclerosis, it's 3 times that. I don't think this is by coincidence. I think one of the reasons is you may have brainstem pathology that may affect muscular tone in the pharynx, and people with multiple sclerosis are more likely to have sleep apnea. So please, if you worry about somebody with chronic fatigue, you're getting a history of poor sleep, not waking up feeling refreshed, don't rely on body habitus, neck size, obesity. This happens in people that are normal BMIs, etc. You need to formally study them. And the good thing about COVID now is the rapid adoption of home sleep monitoring for sleep apnea. So our sleep labs now send people home with pulse oximeters and a little device that measures their respiratory excursion, and it's basically like going out with a halter. They go home and have a sleep study done at home, and it's remarkable. Once you've diagnosed them and you treat their sleep apnea with CPAP, it just transforms their life, and a lot of people's fatigue improves. I won't say disappears, but it improves. So that's a common cause of severe fatigue and sleep disorders in people with multiple sclerosis. Now, you've just had a lecture here. Do you think she's cognitively impaired? What are the risks? So let's go back and do another survey.
I would like to encourage everyone to participate in this poll. We will give like 10 seconds.
Okay.
Okay, I'm
now
ending
you've
the
got
poll
to.
now.
Again, about half the people think she's cognitively impaired. So you won't know she's cognitively impaired until you do until you assess her cognition. Okay. So as you know, cognitive impairment goes up with disease duration. So she's had the disease 14 years. She's got secondary progressive multiple sclerosis. She's lost her job. And I can tell you now, she lost her job because of cognitive issues and mental health issues. Okay, and so when we sent her off for formal cognitive testing, she had quite significant neuropsychological assessment and had quite significant frontal and also had problems with memory. And so we had to do a cognitive assessment on her because she needed it for her occupational health assessment to help her get insurance policy payout. So this lady had cognitive impairment, and at this stage of her disease, more than half, that's probably about 60 to 70%, will have significant cognitive impairment in at least 2 domains. So she is cognitively impaired. Next question, are any of her medications contributing to her fatigue? While you're doing that, I just want to say to you that people with cognitive impairment are also fatigued. And, they're the ones that also complain about mental or cognitive fatigue. And the reason why they do that, though, is when you look at functional MRI scans, when they do cognitive tasks, they have to activate or use so much more of their cerebral cortex in terms of oxygen consumption. We use bold imaging to achieve the same task. So although people with multiple sclerosis can often achieve task X or task Y, it takes a lot more mental energy, in inverted commas, energy consumption to achieve that, and they suffer from cognitive fatigue. And that's why people with multiple sclerosis have a lot of problems multitasking, for example. Okay. What do you think about the medication? Do you think the medication is contributing to fatigue?
So I'm ending the poll now.
Good. Okay, there's a 16% no. Well, I must point out that when you look at the side effects of baclofen is seriously sedating and makes people feel tired. And I call these people baclofen zombies. So I have a lot of experience of people who've been on very high doses of antispastic medication baclofen in combination with gabapentin in combination with clonazepam. And then they get so severe, we have to send them off to have a baclofen pump inserted. And when you put the baclofen pump in and you just give the baclofen to the spinal cord, it doesn't go up to the brain, and you manage to get them off all the other medications. These people wake up, their cognition clears, they are alive and awake, and they say, goodness me, I had no idea I felt so bad. And so I call them, and so just be aware that in people with cognitive impairment, tiredness, fatigue, concomitant medication can make fatigue a lot worse. Now, what do you think about oxybutynin? So oxybutynin, in my opinion, is one of the worst drugs to use for bladder dysfunction. This is a first generation, okay, and it should be taken off the market, in my opinion. It's cheap, and it's used commonly by our continence advisors in the United Kingdom because it's so cheap. But this, as you know, is an anticholinergic, and it gets into the central nervous system, and it makes cognition a lot worse. And there's been numerous studies. The first study that came out was done by Claire Fowler at Queen Square, showing that in MS patients, when you actually do IQ tests, okay, neuropsychological tests on oxybutynin, and then you remove it and repeat it, they improve by 7 points. 7 points. Okay, and the same thing has been done by a Canadian group in London, Ontario, showing exactly the same thing with oxybutynin. And I think this is a message. We should not be using CNS penetrant oxybutynin. If we are going to be using anticholinergics, trospium is the best. It's a third generation drug that doesn't cross the blood-brain barrier. Even the second generation ones, things like tolterodine and solifenacin, they cross also. So I don't like using them now. And I prefer to try use betmiga for bladder dysfunction, which is a beta-3. And if that doesn't work, I add in and I'll use a combination of betmiga with trospium, for example. The problem about trospium is pretty potent, and they often get a lot of dryness in the mouth, and some people can't tolerate that. So yes, I think this lady should have her medications optimized, oxybutynin taken away, and maybe the baclofen needs to be thought about carefully. In my experience, gabapentin and pregabalin are also antispastic, and they work a little bit better, particularly at night because they've got a longer half-life. And they're not quite as sedating as baclofen. Oh, by the way, when it comes to anticholinergics, we as neurologists prescribe a ton of tricyclic antidepressants. Amitriptyline, some people use clomipramine, imipramine. These are really potent anticholinergic effects. That's why people get dry mouth with them. And they also link to cognitive impairment and making it worsening cognitive impairment. So I actually think, and there is a little calculator online, just look up and you can plug in all the drugs, and it'll give you what we call the anticholinergic burden. And you as neurologists should be aware of this, because now in the general population, if 2 to 3 years of exposure to a potent anticholinergic, and this includes over-the-counter antihistamines, okay, increases the risk of getting dementia, Alzheimer's disease, by a factor of over 3. And that's been repeated now in several epidemiological studies. So at a population level, anticholinergics are bad. Never mind people with multiple sclerosis that have loss of reserve and damaged brains. They are much more susceptible to the CNS side effects of anticholinergics. So if there's one message I want to get across to you today is go away, and when you see your MS patients, think carefully about using anticholinergics, CNS penetrant ones. And if you have to use, if you think about using a tricyclic to help with pain and sleep, I've switched almost completely to duloxetine, which has much less anticholinergic side effects, and it's actually got a license for central pain syndrome. So I actually been finding duloxetine a really good replacement for the way I used to use amitriptyline. Do you think this lady has a metabolic disorder like hypothyroidism? Question. Ten seconds to answer this, and once you've answered it, we'll go through that.
Okay, I'm ending the poll now.
Okay. Well, there is no right or wrong answer here, by the way, because you don't know, okay, until you do the test. Yeah, so, you know, often hypothyroidism, particularly early on, doesn't manifest with clinical signs. And the reason why I say this, though, is you're probably aware that autoimmune thyroid disease is probably double, the background rate is probably double in MS patients. And I think the lifetime prevalence in multiple sclerosis reaches about 15%. And so until you test, you don't know. And it's not only hypothyroidism. So when somebody like her comes to me with fatigue being their main problem, I do a metabolic profile on these patients. I check their U&E to make sure there's no renal failure or electrolyte disturbance, because they can also cause fatigue. I check the liver function test, and I check their thyroid function tests. And the reason why I do that is because you don't want to miss a metabolic problem. You don't want to miss anemia, for example. I also include a full blood count and B12 and folate. I don't want to miss one of the systemic metabolic disorders causing hypothyroidism. She does mention something very interesting, that her fatigue gets worse during menstruation. And I really need to write this up, but I haven't studied it. I haven't got time to study it. But I've got now a small collection of female patients with multiple sclerosis who talk about their fatigue getting worse during the second half of their menstrual cycle. And there is biology around this. As you can see, in the second half of the menstrual cycle, the body temperature goes up by about 0.2 degrees centigrade on average. And actually, women who use a rhythm method often use this to find out when they're fertile, either to avoid pregnancy or to fall pregnant. Okay. And this change you may think is irrelevant, but for a person who's got demyelinated axons or remyelinated axons, the safety factor of conduction has been markedly reduced, and small changes in temperature can cause conduction block. Okay, this is why we have temperature, and this is a part of temperature-related conduction block. And I've noticed that when you have a person like this, just putting them on anti-inflammatories, and I'm talking about a long-acting NSAID or even paracetamol, blocks this temperature rise, because this temperature rise is driven centrally, is probably driven by COX. And I found that blocking the temperature rise actually improves their fatigue. So I've got a few patients who take long-acting non-steroidal anti-inflammatories across the second half of their cycle to manage their fatigue. So look out for it. And if it does happen, feedback to me. I think we need to do a study on this. And this may also explain why there is good background evidence that aspirin is the one that was studied at the Mayo Clinic. But there is evidence that aspirin also helps MS fatigue. And I think it's helping by lowering your body temperature. And even in normal people, taking a paracetamol dose we've got a diurnal variation to our temperature, and it always goes up in the second half of the day or late afternoon. And taking anti-inflammatories stops that from happening. So I actually think even in normal, well, in not menstruating patients, you may find the same thing. Okay. All right. So I think she does have a metabolic problem in a way. She's got catamenial fatigue, which you can call as part of her metabolism, and we may be able to hack her metabolism by giving her an anti-inflammatory to improve her fatigue. Okay. Now, the question I'm going to ask you, is it worthwhile switching her from fingolimod to saponimod? Okay. Now, the reason why I say this is another reason why people with MS are fatigued is it's called sickness behavior. So sickness behavior is a evolutionary behavioral response to inflammation that goes back hundreds of millions of years in evolution. Actually, dogfish, catfish, these are cartilaginous fish, have sickness behavior. When they get ill, they stop moving. They tend to sleep, okay, and they lose appetite. And this happens in people with multiple sclerosis and normal people. When you get influenza or COVID, for example, you get a temperature, you get sore muscles and joints, you feel depressed, you feel tired, and you lose your appetite, and you go to bed and sleep. That behavioral response is called sickness behavior, and there's a characteristic loop that works via the anterior cingulate gyrus that drives that behavior. Okay, and obviously that's to try and optimize your recovery period. Okay, and so we now know that people with multiple sclerosis who are fine and get fatigued, often when you scan them, they may have active lesions. And what's probably happening is they've got recurrent inflammation in their central nervous system, which drives sickness behavior. And the two cytokines that have been linked to sickness behavior are interleukin-1 and TNF-alpha, and both of those have been shown to be upregulated in the central nervous system in people with multiple sclerosis with active inflammation. And so the question you have to ask yourself, has this patient's MS disease activity emerged? Have you voted already?
Yes, the
Okay,
results are showing.
Yeah, so most people want to switch her. 16% no. So let me explain to you that a few years ago, I would have said no. I would have said saponamide is a second generation S1P modulator. This person's on fingolimod. Fingolomid's doing the job, but stopping relapses, stopping MRI activity. Switching her to saponamide is going to make no difference. Okay. I've changed my mind, and I'll tell you why I've changed my mind about that. And also in the UK, up until very recently, we wouldn't in the NHS, we wouldn't be able to switch this lady. The reason why is this particular individual would have had to have relapses or new MRI activity to be active in inverted commas to be switched to saponamide. The NHS has just changed that rule, and that was lobbying by us because we were saying that this lady is not having relapses of MRI activity because fingolimod is doing what it's meant to do. It's stopping focal inflammatory activity. And it would be unethical to stop Fingo and wait for her to have rebound before we gave her saponamide. The reason why I've only got saponamide here, because this is the only drug that will be licensed within the NHS, or the only drug on our algorithm for a person with secondary progressive multiple sclerosis. Now, the reason why I've changed my mind is based on data. So as you know, there are big differences between Fingo and saponamide. First of all, fingolimod works across multiple receptors, but saponamide works on the S1P and 5 only. But the important thing about saponamide, it's an active therapy. Okay, fingolimod is inactive and has to be phosphorylated. And saponamide probably has greater activity on S1P5, which is the receptor within the central nervous system on glial cells, astrocytes and oligodendrocytes. And what we've shown in the clinical trials that people on saponamide were much more likely to have improvements or it's a delayed worsening of cognition, whereas with fingolimod, we never shown that with fingolimod. And in the primary progressive fingolimod trial, there was no improvement or change in cognition. There was no change on MTR when we looked at magnetization transfer imaging. In other words, it's a remyelination marker. There was no impact of fingolimod on whole brain volume loss in the primary progressive population. There was no impact on cortical gray matter volume. Whereas with saponamide, we saw all that. So saponamide, we saw positive changes on MTR that correlated with cognitive improvement or stability of cognition. We saw a reduction in gray matter volume relative to placebo. We saw a reduction in brain volume loss relative to placebo. So in the progressive populations, I know we're comparing PPMS with secondary progressive MS. I think they're the same disease. Saponamide had an action within the central nervous system. So based on the data from the EXPAND trial, I am now taking people that are on fingolimod who have become progressive, and we are switching them to saponamide based on the biology and the results from the EXPAND or the secondary progressive trial. Okay, so that's just a aside. And then finally, you don't have to answer this question, what else can we do for this patient with multiple sclerosis? So up until now, we're going to treat her mood disorder. Okay, we are going to optimize her bladder dysfunction, so she sleeps well at night. We're going to change her medications around spasticity, and we're going to take her off oxybutynin and put her something that's not CNS penetrant. We're going to arrange for her to have a sleep study to see if she's got obstructive sleep apnea. We're going to do a metabolic screen and make sure she doesn't have a metabolic problem. And we're going to prescribe a long-acting anti-inflammatory to manage her fatigue in the second half of pregnancy. But what else can be done to improve her management? And this is where I've brought across this concept of marginal gains. Now, to explain marginal gains, I'm going to use a sporting analogy. So you may or may not like Olympic sports, but the one in the UK that we love is cycling. And this is the British cycling team. This is Team GB, and how they performed in the Olympic Games in terms of medals. And you can see, up until 2000, Okay, they were also RANs. You know, they came 12th and they only won 2 bronze medals. Back in '92, they came 4th and they won 1 medal, 1 gold. And then something started happening around the turn of the millennium. They went up to 6, they came 6th, then came 3rd, and ever since then they've been 1st. And you can see their haul of medals has been amazing. And what happened was they actually hired a sports manager. His name is Dave Brailsford. So he started working for the British cycling team in 1997, and he was given the full-time overall job as chief exec or the manager of the team in 2003. And he brought in a philosophy that hadn't been applied before to the cycling team, and this is called marginal gains. And it's very, very simple, and this is him. The whole principle came from the idea that if you broke down everything you could think of that goes into riding a bike and improve it by 1%, you will get a significant increase when you put them all together. And I think if we apply this to MS, if we break down everything we can think of that goes into improving MS outcomes, then improving them by 1% will get a significant increase when we put them all together. In other words, we'll improve this patient's quality of life and outcomes. And so this is why we are beginning to move beyond just focusing on no evident disease activity. We're beginning to wonder, can we change our therapies to prevent end organ damage? And can we use more aggressive biomarkers as our treatment target? But also, can we start doing clinical trials to promote neuroprotection, remyelination, and restoration? And can we focus on brain health? And so this is what I call the holistic management of MS. And so we need to move beyond treating her just with anti-inflammatories. Now, this pyramid here, adding on neuroprotection, remyelination, and neurorestoration, this is a drug development program, okay, that's occurring in the pharmaceutical industry, and that's happening. You know, we're moving to an area where we're going to be trying to build a sandwich of treatments. What we are not focusing on enough are the so-called non-MS targets, things that make the brain unhealthy. So if this lady was a smoker, she's got to stop smoking. She's got to stop drinking alcohol or cut down her alcohol consumption as much as possible. We've got to get her to exercise. Now, she may complain that she's too tired and fatigued, but that's not an excuse, because one of the reasons why MS patients get tired and fatigued and can't exercise is because of deconditioning, which is another term for being unfit. So she needs to be referred to a physiotherapist and given an exercise program. And there's a big debate going on about should they be doing aerobic or HIIT. This is high intensity interval training. The data for HIIT's very profound. I think HIIT's superior to aerobic exercise. So, you know, if she can't do HIIT initially, she should start off with an aerobic exercise program. And it's not enough to go once a week or twice a week. They need to do about 50 minutes a week. So 5 times a week is what I tell patients, and at least 30 minutes a time to get 150 minutes. And they need to raise their pulses, to 60 to 80% of maximum if they're going to do moderate exercise. If they're doing HIIT, which is short periods, they need to get their heart rates above 90% of maximum as part of a proper HIIT program. And they need to do that at least 3 times a week. And ideally, in an ideal world, you'll be doing both HIIT and aerobic, okay? Diet, you've got to optimize their diets, and there is now a lot of basic science coming out around caloric restriction, intermittent fasting, ketogenic diets, and even nutraceuticals promoting brain health. I'm not going to say we should definitely do this, but I think there is research that's happening, and there's research from animal models showing you that these diets make a difference in terms of neuroprotection, and there is real biology and science behind these diets. They probably all stimulate ketogenesis, and there's one ketone body called 3-hydroxybutyric acid that probably binds, it works through the HCA2, the hydroxy carboxylic acid 2 receptor, and that stimulates the signaling pathway in cells, okay, that increases a transcription factor called NRF2, which is neuroprotective and promotes brain health, okay? Interestingly, that particular pathway is the exact same pathway fumarates work on. So dimethyl fumarate works on that pathway. So there is a science behind making sure people improve their diets. I've already mentioned sleep hygiene. Comorbidities is a no-brainer. You've got to sort out patients' comorbidities. I've already mentioned metabolic problems, infections. Now, there is some evidence that people with progressive MS or advanced MS who get recurrent infections do worse. And so you have to try and prevent them. This particular lady didn't have that problem, but other patients like her are getting recurrent urinary tract infections. So you need to manage that aggressively. And there is things you can do as a neurologist to reduce bladder infections, okay? Periodontal disease, another one, recurrent sinusitis, and if they're really advanced, recurrent aspiration pneumonia, respiratory infections. So these are things you should screen for and target in all patients. I've already mentioned concomitant medications, get them off anticholinergics. Anti-aging medications, so not apply to this woman, but HRT, hormone replacement therapy, is anti-aging. There's a whole literature on that outside of MS, and there are trials going on. My personal opinion is every woman who goes into the menopause should go onto HRT, and particularly people with multiple sclerosis. It's only people who have a contraindication to HRT shouldn't go onto HRT. I put metformin there because there are trials going on in MS now using metformin to try and manage MS. By the way, metformin also transactivates that transcription pathway that increases NRF2. And in the aging community, metformin is an anti-aging drug. I've already mentioned to you that this woman has got problems with her social life. She's socially isolated and lonely. And don't ignore that, because there are things you can do as a healthcare professional to signpost these patients to social services. I don't know what happens in your countries, but there are things that can be done. And we know now that social determinants are a potent predictor of poor outcome across multiple disease areas, not only neurological diseases. And so if you can you signpost this patient to services which they can increase their social capital. You know, social capital is basically social connections. This lady needs to be plugged in as a patient into activities that increase her interaction with society. And then I put here wellness. Wellness is a general term that refers to not only physical and mental health, but spiritual health, environmental health, how you interact with your environment, occupational health, etc. So it's the whole package. We can't do anything about wellness programs. We try to start a wellness clinic in the NHS. Some healthcare systems have wellness clinics. If you do have a wellness service, please refer this patient into a wellness service. It'll help. So I'll stop there and take questions.
Well, thank you, Professor Gavin, for a very enriching session. And yes, actually, we'll take some questions. So the first question, is siponimod superior on fingolimod over fingolimod on the cognitive aspect, or only, or also on disability progression?
I don't know that, Lena, because the two drugs haven't been targeted head to head. But I think they're probably the same ballpark, in my opinion, as anti-inflammatory drugs in terms of stopping relapse and MRI activity. But I think the advantage of siponimod is that we have data in progressive MS, which we don't have with Fingo. We have CNS effects based on the beta activation of the S1P5, and because of that, I feel like we should be switching people with more advanced disease to siponimod based on the effects on memory and cognition and the gray matter. But in terms of progression, I don't know about that. But I would say you're not going to. Because we saw in the clinical trial that siponimod reduced relapse rates, stopped MRI activity, and slowed down disease progression. So it's probably in the same ballpark. Any other questions, Maya?
And what are the DMT that showed improvement in cognitive impairment or stopped the decline of the cognitive impairment?
I think all of them will probably do it to a lesser or greater extent. The problem is that it hasn't been tested in a lot of the older trials. So we saw it we've actually saw it as a post hoc analysis in the original interferon beta 1a IM trial, the Avanex trial. Avanex was shown to have an impact on cognition. We've seen it in the daclizumab trial. And there's been post hoc not in the firm, but outside of the natalizumab trial, we've seen a positive impact on cognition with natalizumab. I think it's just a matter of, if you stop damage to the cortex, you will slow down cognitive impairment. Okay, so but not every. The problem is when you license these therapies, unless you've got cognition as a secondary outcome in your trial, you can't get it into your label. So the drugs that have got it in their label had cognition in their secondary outcomes. And so if you didn't have cognition as part of your secondary, had it as exploratory or tertiary outcomes, the regulators won't allow you to put that in your label. Okay.
And a patient diagnosed with RRMS and with a stable disease, well controlled on his medication in terms of relapses or walking impairment or MRI activity, and is recently complaining of cognitive decline. So does it mean that he is transitioning into the SPMS? Can we consider that this patient is in the transition phase?
Yep. So from my perspective, yes, because I treat cognition as another functional domain. So when you look at the functional domains in the EDSS, cognition is there. And so it's how you define secondary progressive disease. So most of us in neurology like to think of SPMS as being a physically progressive disease. And I have no problem with cognition as being the metric, as long as you've got objective evidence. Now, when you speak to the cognitive people, the neuropsychologists, they feel very uncomfortable labeling people with progressive cognitive impairment. And I ask the question why, and they've got no scientific rationale. They just feel uncomfortable that they're responsible for you labeling them as having secondary progressive disease. So yes, I think we should change our definitions of secondary progressive disease. To be honest with you, Maya, whoever asked that question, I don't have I think MS is one disease. And I think you just got to monitor the different domains, and you've got to manage them based on your monitoring. So yes, somebody can be completely stable physically and be getting worse cognitively, and they've got progressive disease.
And Dr. Suzanne answered a question about measuring brain atrophy, and she said, and also here in Lebanon and most country of our MENA region, measuring brain atrophy is reserved for clinical trial and for research purpose, and is not part of the MRI protocol that patient routinely perform every 6 months or once yearly. So what is the status in the UK, and why do you think that that adding brain atrophy measurement is not feasible or difficult as part of the MRI protocol?
So the problem you have is that the brain atrophy measurements are very susceptible to two things: metrics itself, moving machines, they just change the coil. So there's a lot of error around individual measurements. And so in an individual patient, the measurement error is greater than what you can actually measure biologically. It's fine in trials because you're doing groups. And so when you randomize things, those measurement errors cancel each other out. So what you're looking at is differences between groups. So on a year-to-year basis, the current measurement metric is too noisy for us to rely on that. Saying that, though, if you're doing it over time, every year, and you're seeing a trajectory, you can make a call. And obviously, if the level of atrophy is way and above the measurement error, and we're talking about above 0.6 or 0.8% per annum, then I think you can be quite comfortable saying that person has got progressive brain volume loss. We don't do it in clinical practice, unfortunately. We are about to start a study where we're going to be doing with a company in in Belgium, in Leuven, called Icometrics, where we're going to be randomizing people to having a brain volume loss measurement plus all the other metrics that go with it versus those that don't, and we're going to see how it changes our practice. I think in the future, one of the things that's not so susceptible to this error is just looking at gray matter volume loss, because the problem with brain volume, just like dehydrating yourself, your brain shrinks, or if you know, certain medications do that. Diuretics, for example, do that, or having too much alcohol the night before does that. So, but that tends to be white matter, and the gray matter is not that susceptible to physiological changes. So one of the metrics that may be used in the future is not whole brain volume, but just say gray matter or thalamic volume. Watch this space. I think it's going to be part of the problem about brain volume, though. When you've got brain volume loss, it's too late. You've got to prevent brain volume loss. So my personal opinion is know about the brain volume loss across these different DMTs, but think about choosing the more effective therapies up front to prevent brain volume loss. Trying to respond to somebody who's already lost brain volume or is losing brain volume is too late. And I'm not sure it's reversible by the time that happens. So it's, you know, we've got to think about using our disease modifying treatments as preventive treatments before.
Does any of the disease modifying treatment showed improvement in fatigue in MS?
Yes. I mean, the one that does it the best, in my opinion, is natalizumab. It happens very quickly with natalizumab, and I think that's because it stops trafficking and stops inflammation. We've seen it now with S1Ps. It's actually in the ponesimod phase 3 trial. Fatigue was a top secondary outcome and was strikingly positive. We've seen it with almost all of our high efficacy DMTs to a greater or lesser extent. To be honest with you, when we started using the interferons and glutaric acetate, we didn't monitor fatigue that much. And one of the side effects of interferon is fatigue. So that kind of complicated things. So yes, I actually think fatigue, one of the drivers of fatigue is inflammation. And the more potent your anti-inflammatory, the more anti-fatigue it has. But I think I hinted to in my talk, in this case, that it's not only inflammation that drives fatigue. There are a lot of other factors that need to be taken into account.
And how do we treat fatigue in MS, the fatigue that is not related to depression and anxiety, let's say, or any metabolic disease or sleep disorders?
Yeah, so you got to have a holistic approach. So obviously you got to say, is it physical or mental fatigue? If it's mental fatigue, we tell people to think about their mental energy as like a battery. They mustn't overdo it. They must take frequent rests, and our psychologists give them little training strategies on optimizing the mental fatigue. I try them with modafinil for what it's worth. As you know, modafinil is medicinal caffeine, works on the same receptor as caffeine. With the good thing about modafinil, it doesn't cause a tremor or anxiety, whereas caffeine probably has off-target effects, and people get. I've got some really good responses from caffeine. Sometimes using noradrenergic reuptake inhibitors, either SNRIs, yeah, or helps. Exercise is really good. You'd be surprised. I have a lot of patients who condition themselves. They start getting fit, and all of a sudden their fatigue improves. And I think that's not only in MS, that's across the board. People who exercise are less fatigued than people who don't exercise. And I think that's an important thing, is to put them into an exercise program. What else? These are all...
Taking naps.
Sorry?
Avoid taking naps, for example, during afternoon. Do not avoid long hours of work, continuous long hour of work or activity.
Yep, but taking naps has got a double-edged sword. Sometimes people who take naps then can't sleep at night. And so, you know, sometimes it's not about napping, it's about doing mindfulness or a meditation set, so you don't fall asleep.
Yoga, meditation, yes.
Yep. So I haven't helped you very much. Actually, another one is cooling. You know, if people are very sensitive to heat, particularly in your country, where some people find these cooling suits or cooling vests or taking cold baths helps a lot. And I've got one patient who's got a butcher's fridge. I'm not joking. You know those butcher's fridges where you hang up animal carcasses in? So she's got one installed in her house, and she keeps it at 4 degrees, and she literally goes into that 4 times a day for a half an hour, and that absolutely wakens her up and makes her fatigue go away. I mean, that's the extreme example of somebody who finds cooling helpful.
And I've got Vampira for fatigue?
Oh, I didn't mention Vampira. Yeah, so Vampira almost certainly helps fatigue. So I know it's only licensed for improving walking, but there's good
Yeah.
There's good publications coming out now showing that it also works in other domains, including fatigue. Okay.
Yeah. Yeah.
I mean,
So,
we can't prescribe it in this country for fatigue. I'm sorry, but so you've got to realize that if you're going to use it for somebody there's Lena saying amantadine. So Lena, yes, you can try amantadine. My experience with amantadine is about 20 to 30% of patients find a partial response. It may be a placebo. It's worth trying. Recently there's a trial from the United States showing amantadine made no difference in a blinded study.
yeah.
So just warn your patients about side effects. Yeah, as you know, there's a small incidence of hypomania or mania.
Yeah.
And one of our doctors in this country got into a lot of trouble from the medical legal perspective because he didn't warn the patient formally about the risk of mania. Okay, and this patient had to be sectioned and put into a psychiatric institution because of her mania around amantadine. So that's one of the side effects you've got to be aware of.
And a final question, Professor: do you routinely measure fatigue during the follow-up visit for your patients?
Yep. So we got a battery of tests that patients self-monitor. So before they come for their follow-up appointment now, they go online and do an EDSS calculator. They go online and do a cognitive test, which is an online SDMT. We get them to do their own 9-hole peg test, their own walking times, and we also get them to do, there's a mental health thing about depression, and we get them to do fatigue as well. So that, to be honest with you, Maya, not all the patients do it. So we've got about a 60% adherence rate, despite us emailing them and contacting them and saying, complete your self-monitoring, come to clinic. When they punch up at clinic, they haven't done it. So this is, even though we put in place what we would call annual self-monitoring, and this happened over COVID, we put all this in place. Our adherence rates are not that great.
Those were all the questions. Thank you, Professor Gavin, for accepting our invitation and for being our speaker tonight. And I will see you physically next week during the ECTRIMS Congress in Amsterdam,
okay,
and in MNECTRIMS in 2 weeks, inshallah. And with Professor Gavin very enriching presentation and discussion, our virtual clinic series come to its end. Thank you for our esteemed speaker. Thank you, Novartis, for sponsoring this activity. And a big thank you goes for you, our attendees, for staying with us until the end. I would like to remind you that you will receive your certificate of attendance by email within 1 week from today. And if you missed any part of this webinar or would like to revisit the lectures, you can check our IVPN Neuropsychiatry library, where we post all the recordings. Follow us on our social media platform and stay tuned for more educational activities in November. Until we meet again, stay safe and have a good night.
Good night, Maya. Goodbye.
Good night. Bye-bye.